Dear colleagues, it's an honor for me to talk here in front of you. And I have also a disclosure to make. I did my doctoral thesis as well as my habilitation on a Leica research microscope. So, and I will also show you about the long-standing tradition between Rostock and the Leica company. Further, and this will be part of my talk, is to emphasize how important a complete resection of a high-grade glioma is. And I will show you what's so special about Leica, how Leica can help you to achieve these complete resections. As I said, there is a long-standing cooperation between Rostock, before I came, and Leica. We also have an animal operating course. This is a pig, where we teach young residents to operate cranial and spinal anatomy on the pigs. Here you see a format of the course, and it's also sponsored by Corza and Brown and others. And we are pretty successful, so we meanwhile have 3 courses a year. Before I start about the resection, I would like to emphasize the contribution of Northeast Europe to neurosurgery. You heard about the Cushing reflex. It is a reflex where the blood pressure goes up by intracranial pressure. And Cushing published it in 1901. But about 20 years before, Professor Bergmann, who was in Eastland and later on in Würzburg and Berlin, has published in his habilitation thesis the same reflex. And because the world was not connected, these both researchers, Bergmann and Cushing, had the same invention and published it completely independent from each other. Further, one has to raise that Professor Quincke invented the lumbar puncture and the measure of the intracranial pressure through a lumbar puncture. So far to the Northeast contribution. And why is complete resections glioblastoma so important? When I was a student and became a resident in neurosurgery, experienced surgeons told me, hey, this is a dead science. In the next 10 years with gene therapy, we just make a gene therapy by infusion and the glioblastoma will melt away. You will only decompress trauma and stroke and but the tumors are out because we're going to invent the genetic therapy. And they talked about magic bullets. So far as we all know, there is no magic bullet still. But nevertheless, the overall survival in glioblastoma has improved over the last 10 and 20 years. And I show you why. What do we have against the glioblastoma? We have steel, beam, and chemo. A good craniotomy and resection. Beam is fractionated radiotherapy with 5 grays. And the chemotherapy is with lomustine or temozolomid as a CTEC therapy or a temodal therapy. What's now emerging is the tumor treating fields, which are electric fields which alternate and inhibit cell division. And what is new, at least in Rostock, is a nuclear therapy similar to a thyroid cancer where we poison the glioblastoma with a radioactive substance, lutetium, over the GRPR receptors, which are very common in the glioblastoma. And what is further possible is if you have certain mutations or alterations of the glioblastoma, you can do an immunotherapy against it. You are pretty successful if you have a IDH or BRAF mutation, but as you also know, the glioblastoma hasn't got it. So it keeps on the surgery, on us. And I will show you now how important the extent of resection is. Here is a publication from famous Mitch Berger, 2008, where he also compared whether of a where you leave a little bit tumor inside, where you can compensate it by radio or chemotherapy. And this is not the case. If you do a clear resection, your percentage of surviving patients after a year is still higher with a complete resection. And a few years later, more clear paper came out that the extent of resection is if you leave 10% of the tumor inside, and whereas you remove the whole tumor, your survival is improved over a year. So about 2 years with incomplete resection, whereas 3 years with complete resection. So the total resection is the predictor of a good outcome. What is a good resection is, you call it EOR, this is the tumor which we operated just last week in the speech region. Here you see the contrast enhanced, and this is a complete resection. All the contrast enhanced has been taken out, but what is the white stuff? If you compare the T1 without gadolinium and the T1 with gadolinium, you see it's all the same. So it's a little bit old blood, and you can see the vessels over here. So this is really with contrast enhancement. So this is about to achieve. And there's only one good thing about gliomas, a high grade. They take up the 5-ALA, which goes to the mitochondria, and because the glioblastoma have such a high mitochondrial activity, it takes up the fluorescence, which can be made with visible with blue light. And here we show a work of Stummer in 2006, where he showed that he gets the complete resection done with 5-ALA, and that the patients who were operated with 5-ALA survive longer than patients without 5-ALA. Here you have an odds ratio compared to the patient cohort, and you see the overall gross total resection is a benefit for the patient if you compare it versus standard resection. So it's important to remove all ALA parts. This has been shown in this study. Now, these days, you might argument that the MGMT status is even more important than the complete resection. And this is the work of our Frankfurt time, my deputy, Professor Gessler, and he has shown how the MGMT status influence complete and incomplete resections. And you see again that the complete resections with the MGMT positive state here and the MG negative state still are better than an incomplete resection. Now, this is a publication from last year. This is a major German study of a lot of centers, and they compared whether they can achieve complete resection under 5-ALA and compared it to intraoperative MRI, which is a kind of gold standard. And they published it pretty high in the Journal of Clinical Oncology, and you see that the progression-free survival of 5-ALA versus intraoperative MRI is the same. Same is overall survival, it's also about the same. So 5-ALA can achieve equal results as the gold standard, the intraoperative MRI resection. And now everybody knows how the resection with ALA goes. You have it on the blue light, the tumor shines here nicely in reddish, but if you put the white light, you see the whole anatomy. So everybody can imagine if something starts to bleed, you don't see the tumor anymore, or you can hurt the vessels in the darkness. So wouldn't it be nice if you could combine the visibility of the tumor, the fluorescence, with a good white light pictures? And this is the video again. And this is what is achieved with the GLOW400 Anatomy View program. You see here the classic ALA of a case last week. You see here the tumor as you know it, and this is the augmented reality with GLOW400, the anatomical view. You see also the vessels. And this is an important message. So why is that beneficial? You still see the tumor, you still see the anatomical details, which was not possible without the augmentation, and which makes it less that you switch in between the blue and the white light mode. This improves your workflow and your concentration, and the fatigue in long resections is improved. And sometimes you know it also, where are the borders? How to differentiate my tumor from where to stop to resect. And this is the classical view here of the blue light, and this is another augmented reality. It is called HiFluo view. The fluorescence, you see it with a higher contrast, and also low fluorescence is better visible. Just compared classic and the augmented reality. And this is augmented reality which fits very perfect into your workflow and to your resection mode. And in addition, the microscope has a large 4K 3D monitor where you can discuss these results and your extension of resection with your colleagues. And this was a thing which always kept me at university hospitals, that in case of a difficulty, you can call somebody, even if you are the chairman, and still discuss the case. And if you need to change on the microscope, it's difficult to discuss. But if you have it on the excellent monitor, it's more easier. And here again, anatomical view of the fluorescent tumor, and you see our strategy is going around the tumor beyond the vessels and resect it on the tumor boundaries and take out all the fluorescent stuff of the tumor by seeing still the anatomy. And this is the high flow view. You better see small fluorescences, and you can distinguish where the tumor mass is if you are not happy with this distinction in the anatomical view. And here you can compare these both views. You can compare it on your headset, which my colleague, Professor Kuzman, has introduced to you. And you can also compare it on in the microscope, of course, and on the monitor. And with this, you see, even in small fluorescent tumors, a better view of the tumor, and which enhances you or improves you to make a better resection. So I make sum up. The Avio microscope, you have the benefits of brilliant optics, and I think this is still the key stuff. Exoscopes with cameras, it's all nice, but I believe in lenses and excellent visual quality. By all the counting and the computer mechanisms in an exoscope and so on, nobody has taken in mind how well your internal processor, your brain, and your visualization of the optics is inside your brain. There are no bits and bytes. Nobody has counted this into it. So I think lenses are the gold standard, and this microscope has excellent lenses. You still have, in a kind of free, buy one, get two free, an exoscope, as my colleague has demonstrated to you. So, but an exoscope with lenses. Then this real-time augmented fluorescence. It's on demand, it's there, no delay, and you see it. And you have an excellent monitor, 3D 4K, for discussion with your colleagues, and the MyVeo headset is integrated. So there is no cable, not much, there is one cable and it all works. What are the benefits of this new augmented reality, the GLOW400 view? It is the possibility to see anatomy. It is the possibility to see even low fluorescence with the high fluoro view mode. And you still can have each picture as mono or as double and compare together. You have less switching between the white and the blue light, and which improves your workflow and your concentration and minimizes your fatigue. In the end, I would like to end with a picture of my colleagues, which substitute me in the hospital, and without their presence, it won't be possible for me to be here. Thank you very much for your attention.